for both the T cells and the B cells, before they do anything, they have to find that antigen that matches their unique receptor, right? And then once that occurs, the T cell or B cell then has to be activated either by one or more steps. So like in the T cell, first it identifies that antigen, then there has to be co-stimulation that occurs, and then that T cell activates, divides, and starts attacking or helping, depending on if it's a helper or a cytotoxic T cell. For the B cell, we saw that there's another step in the process where first a B cell has to be sensitized. In other words, it has to find its antigen free in the body, not associated with an MHC molecule. But then before that B cell will become a plasma cell, it then has to interact with a helper T cell. So what that means is you do not form antibodies unless you have working B cells and working T helper cells. So you have to have both. Now, the cytotoxic T cell pathway, which we talked about here, it can function without B cells. So B cells are not necessary for T cells to work, but T cells are necessary for B cells to work. Okay, so it's sort of it's not exactly symmetric. Now, what we're going to do today is we're going to take these ideas and kind of see, all right, well, what happens then in the body? Let's take these pieces and kind of put them in motion in a real scenario. Okay, so one of the first things we're going to talk about is how the response of antibodies, in other words, how many antibodies and how quickly are they made, varies depending upon if you've been exposed to that particular antigen before. All right, so for example, this is our primary response. All right, so what is this curve showing you? This is time along the bottom. This is how much antibody of a particular type, in other words, how much antibody against a particular pathogen or antigen are you making. So at time 0 here is exposure. So, somebody sneezed on you and the virus made its way into your nasal cavity, let's say. So that's the body's first opportunity to see that antigen, because that's the moment of exposure. And you'll see that nothing really happens for about half a week. So for 3 or 4 days, the acquired immune system doesn't really do anything because it has to develop that immune response. It takes time. And then about day 3 or 4, we start to see antibodies being made. And the first group of antibodies we see are the IgMs. So you remember that the IgM is this guy, looks like a snowflake, and I said it's the first to appear, right? So we're seeing that in this example. So about a week, between a week and 2 weeks in, the IgM concentration peaks. Now this is in a primary response, in other words, a first exposure to a thing, right? Because we'll see that it's very different the second time you see something. So IgM goes up, and then IgM production starts to decrease. Now, somewhere along in here, typically for a viral infection, you're looking at 5 to 10 days of symptoms, right? We've all experienced that. So 5 to 10 days is about here to about here. So we can see there's a correlation, at least, that as IgM concentrations go up, symptoms start to go down. This is one of the reasons I say that antibodies are that silver bullet that ends up killing off the infection, because we see these patterns. All right, so IgM goes up and down. Now, not long after the IgM starts being seen, we start seeing IgG levels go up. And IgG is this category. These are the most numerous antibodies we have, and they are predominantly circulating antibodies. In other words, they're found in the plasma, they're found in the bloodstream. So after exposure, about a week in, we get our IgM peak, and about 2 weeks in, we get our IgG peak. Now, usually by this time, you're cured, right? The infection has been eradicated, or at least nearly so. So we see that even IgG now levels start to decline. And the reason for this is there's no point in making antibodies that aren't useful for anything. Okay, so yes, these antibodies did their job. They wiped out this infection, or they assisted the immune system in wiping out that infection. But we see that in an initial exposure, the levels eventually go back down almost to zero. Now, it's never totally to zero, but they go very, very low. Okay? So this is the first exposure routine. First we get IgM, then we get IgG. Well, what about the second time that we're exposed to the same virus? So this only works same virus, second exposure. Well, we get a very different response because of a different attitude, so to speak, from the immune system. First, you'll note that the increases start right here at time 0. Do you see how there's this 3 to 4 day lag before antibodies are produced at all? It's because the immune system doesn't know anything about this pathogen. You know, it's naive, we call it. You know, so there are no memory cells. There is no predetermined reaction yet to this pathogen. Well, the second time you see that same virus, though, there's an immediate response because the immune system hasn't forgotten about this pathogen. It has just stopped reacting to it. All right, so second response, and we see a rapid, not just IgM increase, but IgG as well, and a huge IgG increase. And as we watch the IgG levels over a month or over weeks here, we see that it does decline, but it's getting nowhere near zero like it did the first time. So this secondary response can result in a lifelong level of IgG to that particular antigen. So this is why we give booster shots for vaccination. So the first time you get a vaccine, this is how your body responds. It makes a little IgM, it makes some IgG, but the immunity levels, the antibody levels, go down almost to zero. So then some weeks or months later, we give you another vaccination, oftentimes the very same one, and now we get this pattern instead. So the body sees that as a second exposure, and the IgG level goes way, way up, and it stays up over a long, long time. Now, you'll see IgM doesn't follow that pattern. These two curves pretty much look the same, only this one occurs at time 0 instead of time 3 or 4 days, right? So IgM is always temporary. So even if you are being exposed to a virus you've seen 100 times before, the IgG level is still going to be high because you've had all that exposure, but your IgM level is going to go up and down every time you're exposed to that thing, right? And we can use that characteristic if we want to find out if a person has been recently exposed to a particular virus. You know, so right now measles is going around in some places. And, you know, how do you find out if a person who is immune to measles because of vaccination, have they been exposed to that measles virus? Well, you can, in fact, do that by looking at IgM levels. If their IgM levels are high, it means that they've had a recent exposure. Now, as long as their IgG levels are high, they're not going to get sick from that exposure because they're going to have immunity already present. But this difference between the IgG and IgM curves means we can detect an exposure, right? In other examples where we're trying to determine if somebody's been exposed to something, IgM is also looked at because it's quickest to appear. So in a needle stick, for example, hopefully none of you will ever have that, but if you end up stuck with a needle that has somebody's bodily fluids on it, they'll test your antibody levels for a variety of different pathogens for several weeks afterwards to see if there was an exposure in that needle stick, right? So primary response, secondary response. Now, yes, we do this for vaccinations, but this occurs naturally too. You know, so many of you were exposed to a virus called the Epstein-Barr virus when you were in high school. Very common. Everybody by the time they get to about 30 has that exposure. Well, so that creates this response. But then if you're challenged with that same virus in the natural world again, your body makes a lasting immunity instead of a temporary one. This makes sense because, we want to have a lasting immunity to anything that we're going to encounter frequently in our lives. Okay, so the second time the body says, well, the second time there's an exposure, now it's time to make a permanent immunity to that. Whereas if it's just a one-time thing, there's no point in making a bunch of IgG if you're never going to see that virus again. All right, so by the time we get through childhood and into young adulthood, we have IgG levels that are very high to lots and lots of different things. Of course, the things that we have had vaccinations for, but also any of the viruses or bacteria that are just ever present in our environment. And that changes from region to region, even from city to city. But we all have a catalog of IgGs circulating around all the time. All right, so, and once you have IgG to a thing, you are immune to that. So, again, vaccines. How do you check to see if a vaccine worked? How do you check to see if somebody's immune? Well, we look at antibody titers. So some of you will have had blood drawn, for example, to see if your measles, mumps, rubella, or varicella chickenpox titers, we call those titers, are high enough. They're checking for IgGs. They're looking for IgG to the measles antigens. The primary and secondary response. Questions about that? This is sort of an important point. So, yes?
So, with allergic reactions, how come sometimes you react worse the second time?
We're going to talk about allergies.
Oh.
Next. Did you read ahead?
Oh, I didn't.
We also see this primary and secondary response effect in allergies because of the nature of the acquired immune system. And that is, it won't do anything the first time it's exposed to a thing. There has to be multiple exposures to create a lasting immunity. So here is our example for allergies. So this is the first exposure case. All right. So let's say you recently moved from Phoenix, Arizona to St. Louis, Missouri, and you are exposed to many new pollens in the air because the plant life is very different in those two regions. Well, some of those, in some people, it's like 15-20%, 10 to 20% of people. Some of those pollens will be seen by the immune system as pathogens. Now, that's an error. That is not how, it did not evolve to do that. Because a pollen is not going to hurt you. It's not going to reproduce in your body. It's not going to steal any of your body's resources. It's not going to create an infection. But because these pollen grains are very biochemically complicated, the immune system gets confused, essentially, in some people, and attacks these pollens like they're a pathogen, right? So how does that happen? Well, here's the allergens. Those are pollen grains. The macrophage gobbles it up because they don't belong, right, in the body. And as it gobbles it up, it then presents pieces of those allergens on its surface. So now it's an antigen-presenting cell, like we talked about last time. So pieces of this allergen are contained in a class 2 MHC on the surface of a macrophage. So that works to activate T helper cells. That also, the allergens are detected by these B cells as pathogens. So we get B cell sensitization because these are not in a cell, so this is a free antigen, right? So it sensitizes it. The T helper cell is activated. The two talk here, and then the B cell becomes a plasma cell. Plasma cell creates antibodies, particularly IgE antibodies, because this is an extracellular pathogen or antigen. So at this point, nothing much has happened in the patient, right? Because they made IgE antibodies, but by the time the antibodies are formed, maybe the allergens are already gone. Maybe that pollen has passed or the person has changed locations. So the patient doesn't know anything happened in this first exposure. Now, it may not be pollens, it may be a bee sting. This is one many of you will have heard about. So somebody gets stung by a bee when they're 3 or 4, and, they get the usual little welt that hurts a bunch, but they don't have any other problems. But then maybe later on, they get stung by a bee again, and they have some massive allergic reaction that almost kills them. right? Well, that is the subsequent exposure piece down here. So the first exposure results in the production of antibodies, and at this step right here, the production of memory B cells, right? B cells that are going to remember that this was a pathogen. Okay, so along comes the B again, stings the same person. So same antigens are now present in the body. There's already existing IgE antibodies, and those antibodies are going, and there's memory B cells. Those two things together mean that this allergen is now going to trigger a massive response by the immune system, just as though it were a virus or a bacteria or a parasite of some kind. So we get the IgE antibodies get stuck to these allergens. That triggers the immune system to respond. So we get histamines, other chemical mediators, and those chemicals, those signals, essentially trigger either a localized allergic response, where you get all the same symptoms as an infection. So when if anybody has skin allergies, nickel is a common one that people are allergic to. So if you put nickel on the skin of a person who's allergic to nickel, and then you take it away, it looks like there's an infection happening. It gets red, it gets swollen, it gets itchy, all the same things you'd have if you had bacteria there. So we get either a localized reaction there. Another example of a local reaction is hay fever, we call it in this part of the country, allergic rhinitis, where pollens trigger an immune response just like you have a cold. Allergies have a lot of the same symptoms as cold do: runny nose, sniffly nose, congestion, all those things. So it is the immune system, after a first exposure, responding to a second exposure a bit like this, with a more vigorous response the second time. Now, in some people, a subsequent exposure can cause a systemic allergic reaction. We call this anaphylaxis. So the classic examples here are bee stings, shellfish, and in some people, peanuts. People who are highly allergic to these things, when their immune system encounters these allergens, it not only reacts locally, it just goes nuts. It explodes. The immune system kind of explodes as though the patient had a massive systemic infection. So their blood pressure drops. Oftentimes the airway will swell shut with leaky capillaries swelling, trying to protect the body from this otherwise harmless pathogen. And it can actually result in death. Anaphylaxis can. So you'll know that a patient is at risk for this if they either carry or talk to you about an EpiPen. Has anybody ever heard of an EpiPen? It's an automatic syringe and needle device that's spring-loaded. There are even some that have a little explosive charge in them. But essentially, you jam it into the person's thigh, and you have to hit them harder than you think. If you've ever given one, you think, oh, I'm just going to poke it in, it's going to go pop. It's not like that. You have to really whack it. But it injects epinephrine into the patient, and epinephrine then reduces these symptoms at least until the patient can get to the hospital. Okay. Did we talk about EpiPens last semester? I think we did. This is sounding very familiar. But public service announcement: if you ever are involved in giving somebody an EpiPen, they will get better, but not for long. Okay. About 15 minutes later, those symptoms are going to return. So that EpiPen is to get them alive to the hospital. It's not to make it better. So a lot of times, kids are like, no, you give me the EpiPen and then I can go back and play. No, you can't go back and play. You have to go to the hospital because you're probably going to need more epinephrine later on. So allergies are the immune system behaving like it usually does, but behaving against an allergen that isn't actually harmful in any way. They're harmless. Okay. So questions about that? Allergies, yes.
So, how could you be, this is kind of going to sound stupid, but kind of allergic to something? When the seasons change, I kind of get, teary eyes.
There's a range. Some people have really severe allergies all year long. Some people have it breakthrough almost. And it's because the way our body deals with pollen in particular All pollen grains are different. So, if you have a ton of pollen, then your body may respond like it's an infection. If you have just a little, you may not have any symptoms at all. This happens with pet allergies too. A lot of people will say, oh, I'm allergic to cats. But they can live with a cat just fine. They just can't pet the cat and then rub their eyes, or their eyes get all red and scratchy. So there's a big range in allergies.
And what about nickel? I'm allergic to nickel, and when I wear fake jewelry, my ear will
swell up.
Yeah,
Mm-hmm.
but none of I don't have any other symptoms. It's just kind of
Nickel is almost always just a skin irritation thing.
Yeah.
And earrings are the most common thing. The other spot that people get it is on their lower abdomen from a belt buckle, or from the snap of a jean or something like that where it's touching the skin. Nickel isn't used as much in clothing as it used to be, but it's still found in cheap jewelry. But both of those spots are spots where the skin is particularly sensitive to, so it's kind of a double whammy. But yes, okay, good, allergies. So the immune system, I've said this kind of all along, but we divide it up into these different pieces so that we can zoom in and we can look at, okay, just this piece, just this piece. But the immune system, it's all one system, and it all works together. So I call this slide teamwork. It's right out of your book. But it gives some examples of some spots where the different branches of the immune system really do work together. Okay, so we've got, this is planet Earth right here with all of its creatures that would very much like to use our resources that we've spent so much time and energy creating in our bodies. And, here's the two branches, non-specific and specific. And we'll see some spots where things interact. Okay, so for example, the macrophages are oftentimes the first cells to start addressing a pathogen, right? By either phagocytosing it and destroying it. The NK cells launch a kind of antiviral attack to kill cells that might be infected. But in the end, it is the non-specific defense cells that end up acting as antigen presenters. Okay, so this spot right here shows you that the non-specific branch and the specific branch interact at a very important spot. So without antigen presentation, none of this stuff can happen. So here's a critical connection, okay? And then the complement system is going to attack bacteria. So it's going to attack with circulating proteins, and it's going to assist with destroying that bacteria. The macrophages are going to destroy those bacteria. And then on the specific side of things, yes, we have a more complicated system. So we've got our cell-mediated system over here, where intracellular pathogens like viruses or intracellular bacteria are going to result in the activation of the CD8 cytotoxic T cells, right? That's the class 1 MHC molecule with an antigen inside, displayed on the surface of some infected cell. When those activate, we get the cytotoxic T cells, the memory cells, suppressor cells, like we talked about last time. And these guys, the cytotoxic T cells, end up destroying antigens, pathogens, and the antigens that make them up, right? And then on this branch, this is the humoral branch. So the antigens end up packaged in these class 2 MHCs. That activates the helper T cell system. Once the helper T cells are activated, they can then assist in the activation of the B cells. The B cells become plasma cells, produce antibodies, and those antibodies do all of these things that we talked about last time that assist the immune system with destroying or otherwise removing pathogens. And just as a reminder, this is a star-worthy slide, this antibodies in action. You should know how antibodies assist the immune system in clearing infection. All right. Because at least in life on Earth as we know it, antibodies really are the final link in our immune system chain. Once you got those, the thing is, whatever it is done. Now, there are a few pathogens that can survive the antibody attacks, but they are few and far between. Tuberculosis is one of those, and it's because tuberculosis hides inside of cells, and it's a very good hider. So even though a patient has lots of antibody to tuberculosis, that doesn't mean that they're immune. It's one of the reasons why, in America, we don't give a tuberculosis vaccine, and it's because to this day, there isn't one that works 100% of the time. The tuberculosis vaccine that's given in a lot of other countries is only about 60 to 80% effective. So we don't give it here because it's not 100%. That may change. But why? Because we can load you up with antibodies to tuberculosis, but they don't work to destroy the bacteria. So instead, you have to attack it with antibiotics instead. It is one of the barriers, antibody production, making this happen right here, is another barrier to why don't we have an HIV vaccine yet. And it's because the HIV virus is not very antigenic. In other words, remember my circles and squares and diamonds? It doesn't have very many of those molecular features, so it's a bit of a stealth virus, which means it doesn't have things that our immune system easily recognizes. So they're working on that too. But this works for 99.9% of pathogens, but the ones that it doesn't work for tend to be the ones that then go on to cause human disease. Hepatitis B and C are other examples of this, where even though you have antibodies to it, that doesn't necessarily mean that you're immune, or it doesn't mean that the antibodies will clear the infection, because some viruses know how to hide from the antibody attack. Yes?
What about different strains of viruses? Can you get a virus and then build up antibodies and then get a different strain of it and kind of
Still
get
get
how does
sick.
that work?
You can
really sick?
You can get sick like it's new. You can get kind of half sick because the immune system is sort of dealing with it, but not quite. That happens in the flu. Because the flu virus is highly variable, so it evolves and adapts and mutates very rapidly. So you got a flu vaccine last year, let's say, and say this year's flu is just a little different, you can kind of get half sick. It's better than not having any immunity at all, but it doesn't keep you fever-free, let's say, from flu for the whole year. This year, they're saying this year's flu vaccine didn't work very well, that they kind of missed the target, because they have to guess, to make 100 million doses of a vaccine, you kind of have to start before the last minute. And so they have to guess what the virus is likely to do next year. And it looks like this year was maybe not the best year because a lot of people got the vaccine and still got the flu. So, but yes, antigens are specific strain to strain. Even in one virus can change in a person over time and slip out from under the immune system. That happens with HIV all the time because HIV, it adapts and evolves very quickly too. So you have a patient with HIV and you start them on a medication. If you only start them on one, the virus will mutate around whatever your thing is, and the patient will start to get sick again. That's why the gold standard for treatment for HIV is 3 or more different antivirals all at the same time to keep the virus from mutating around the intended effect. Yeah.
So would you recommend vaccinating for the flu, or just not getting the vaccine at all?
No, it's worth getting the vaccine for a couple of different reasons. One is herd immunity, which is a virus has a lot harder of a time spreading in a population when lots of people are immune to it. And while most of you, let's say you got the flu, you'd be sick for a week, but you're not going to die, right? But you are around people in your daily lives where if you pass the flu on to them, they might die. Little kids, old people, people with respiratory problems to begin with. So there's that piece. Another piece that people sometimes forget about is when you're sick, you're not productive. So the vaccine may cost $20, let's say, but if it keeps you out of being sick for a week, you'll make that up in wages, or for your guys' sake, you'll make it up in study time and stuff like that. So, no, I would recommend the flu vaccine to everybody. There is so much science behind that vaccine, it's ridiculous. I mean, in some ways, it's a biochemical marvel that we're able to guess pretty well accurately where that virus is going to be every year. And because this is the first year, really, since they've started that program where they really missed the mark enough where anybody noticed. Yeah, so I would recommend that flu vaccine. Other questions? No? Okay. And please vaccinate your kids. I hope I don't have to educate all you about that. Little point about that. So this whole movement about vaccines causing certain developmental disorders in children, it all comes from, well, a couple of different things. One is somebody published a paper that proved this, and the data was all made up. Okay, so this happens in science. It's terribly unfortunate, as you see with the measles coming back in this country, which is crazy. So that's point number one. Point number two, which is something we learned in pediatrics, is it has to do with time. Have you heard the phrase correlation is not cause and effect? In other words, if two things happen in a similar time frame, that doesn't mean one caused the other. And autism and measles fell victim to this correlation is cause and effect. Autism is usually diagnosed between 6 months and 18 months because it's at that point when the child has developed enough to become, to seem different than other children, to have characteristics that are unusual. It is also in that same time frame that the measles shot is given. So what happened in people's heads is the kid got a measles shot at 1 year, got diagnosed with autism at 18 months. Well, this must have caused this. Total bunk. Not true. They just happened at the same time, right? So were you going to ask me something about this? About vaccines and what's the deal with that? Well, and there is the nature of Americans sometimes is once somebody thinks they're right, it is very hard to convince them that they're not. And there got to be this critical mass of people who believed that this science was true even though there's no evidence for it. Because there is some evidence that there's no connection. And that is hundreds of millions of kids every year get the measles vaccine. And if the measles vaccine caused autism, our autism rates would be through the roof. Because still, 80% plus kids get vaccinated according to the CDC schedule. So there's no way that there's any connection there, yes.
Are there any pre-existing health conditions where a child could not receive the vaccine? Because I read this thing that said she didn't vaccinate her kid because he had some disease and it would...
There aren't many. I mean, even kids who are on chemotherapy, they get their vaccines right on schedule. Kids who have even really profound autoimmune or immune deficiency diseases, they get their vaccines. In fact, it's even more important that they get their vaccines. The only exceptions to that are allergies to the components of the vaccine itself. So many vaccines are made inside of eggs, chicken eggs. So if you're allergic to chicken eggs, then you have to get a different kind of vaccine that's more expensive. But there are not very many conditions where you'd say, oh no, don't vaccinate the child. In fact, it's usually you need to vaccinate or even vaccinate extra.
So there's an alternative vaccination?
Yeah, if you're allergic to eggs. Yeah. You might have to go to an immunologist or an allergist to get it, but it's out there. Yeah. Yes?
With measles coming back, I'm just kind of confused on how it happened because when I was in school, you had to, hit certain requirements for vaccinations or they wouldn't let you in. Can you tell me how that was able to happen?
Because the anti-vaxxers felt so strongly about this, they figured out ways around those things. Because one of the ways you cannot vaccinate your kids and have them still be in school is you sign this form that says it's against your religious views to vaccinate. There's no documentation required. There's no second signature. You don't have to have anybody else sign it. So you can just make up a religion all by yourself and say that that's why you're not vaccinating your kids. And there's nothing the states can do about it because it would be discrimination on religious grounds. Yeah. It's not always a good place, our country. Most of the time it is, but yes.
The articles have been like retracted. Why don't they put it more out there, like publicize it more that it's not true?
It is out there. It's that these people, once they think they're right, they think they're right. Because you can look that up. You can look up how each and every one of these anti-vaccination papers has been thoroughly debunked.
Yeah.
And some of it is people think it's a conspiracy, so they read that it's been retracted and they say, oh, that's the vaccine manufacturers. They got to that person and had them retract their work. It's a mess. So vaccinate your kids, okay? Don't make me come hunt you down and teach you this stuff again. Yes.
I think a big problem right now is there's an actress, I forgot who it is, maybe Gwyneth Paltrow or something, who's saying her kid has autism because she gave him vaccinations. And it's like once someone famous says something, it's like, oh my God, they're right.
Like she's an immunologist.
Yeah, exactly.
Or a developmental
and it might not be
behavioral
Gwyneth Paltrow, I can't
pediatrician.
remember who it was, but it's one actress in particular who's saying her kid has autism because of the vaccinations.
Yeah. I used to encounter this all the time. I would have maybe 1 to 2% of my patient population I'd have to give the hard vaccine speech, and I dismissed several patient families because I wouldn't not give them, so they had to go see somebody else. And I know that the physician community is really it's more vigorous than ever now with the measles, because this is proof. This is what we said was going to happen, is that as more and more people didn't vaccinate, our herd immunity goes down. And we're going to start seeing an outbreak of a disease that we had all but eradicated, all because people think something that isn't true. So I'll get off my soapbox. But, it's exactly what they said was going to happen. Yeah.
What about for premature babies? Do we give the same immunization
Yeah.
schedule to them?
Yep. There's 2 schedules we use, and different people tell you different things. So like the CDC schedule says 2 months, 4 months, 6 months, 9 months, 12 months. Now, does that mean the day from the day they were born or the day they should have been born? So some physicians will use the day they should have been born, but most people will use the day they were actually born. Because even a 24-weeker, little tiny thing, has a functioning immune system. Their acquired immune system's ready to go. So, yeah, they can get their hepatitis B. Mm-hmm. And vaccines, particularly the ones that we give in the first year, they're not pathogens. They're broken pieces of pathogens, so they can't infect you. So it's not like, say you've got a child who's struggling to live on a ventilator, let's say. A vaccine isn't going to be another challenge to them. It's not going to affect them at all. Somebody else had a question. Yeah.
Is it ever too late? You know how there's a schedule?
Mm-hmm. It's never too late.
Okay, sounds good.
There's always a schedule for catch-ups. So let's say you had anti-vaxxer parents and you never had vaccines. You can go in and you can start right now and you can get all the same immunity. So there's no statute of limitations or time limit or whatever. You can go in and get your measles, mumps, rubella #1 right now, anytime, even if you're 80 years old. You can. Other ones? Good. This is good. I'm glad we got to talk about that. Be messengers of common sense and science, right? To all of your families and all of your friends. It's crazy. Measles can kill too. It's not just that it's inconvenient. And MMR, measles, mumps, rubella, all go together. Measles causes a rash, fever. Everybody knows that. Mumps used to be a leading cause of sterility in males. And so if you're not getting the measles vaccine, you're probably not getting the mumps or rubella vaccines either. So there's a reason we developed these things, because they used to be major public health problems. So, okay, enough. Done. Okay. So your book points out, and this is a good point, is that bacteria and viruses are treated differently by our body's immune systems. And that's because their life cycles are different. The bacteria, they get in you, and they want to consume your resources, right? They want to eat your glucose, and they want to use your lungs for oxygen and to get rid of CO2 and use your warmth and water. So bacteria cause trouble through reproduction. They expand. The colony levels expand, and you get more and more bacteria in an untreated infection. Viruses, they kill cells typically because the virus infects the cell, hijacks the cell's machinery, makes a ton of virus, and then the cell dies. So here you have cell death, that's the principal cause, and here you have competition, where the bacteria are competing for the body's resources. All right, so the bacteria are dealt with in the body first by phagocytosis. You know, how do you destroy a bacteria? Well, if you gobble it, if you swallow it and destroy its pieces, well, you've destroyed that bacteria if you digest it. So the macrophages and the phagocytes do that. They present those antigens. Cytotoxic T cells can attack and kill some kinds of bacteria, but they are less effective at that than they are at killing infected self cells, you know, normal body cells. So you do get a little bit of that. But mostly for bacteria, we get helper T cell effects and B cells making antibodies. Those antibodies then dramatically improve the ability of the phagocytes to destroy the bacteria. Okay, and then eventually, once you have the antibodies present, then the bacteria are destroyed faster than they can reproduce. Okay. Now, a common misconception about antibiotics is that they are what cures you. No. Typically, antibiotics just reduce how quickly the bacteria are spreading or are dividing, and it gives the immune system a chance to catch up with the infection and destroy it. So, for example, if you're a patient and you have a significantly reduced immune system, antibiotics are usually not enough to clear a bacterial infection. So it's not that the antibiotics are killing the bacteria. The antibiotics are slowing the bacteria down so the immune system can kill off the bacteria. So you got to have an immune system to get rid of a bacterial infection. Now, you can flood patients with antibiotics and kill the bacteria directly, but that's almost never done, only in patients that have some massive immune system problem to begin with. All right. So that's the bacteria path. The virus path, because viruses typically are inside of cells doing their damage, the path is principally, it's this part right here, that the cytotoxic T cells destroy those virus-infected cells, thereby stopping the propagation of that virus through the body. Now, viruses do have to get from cell to cell, which means they're found outside of cells too, and antibodies play a role there, where antibodies get attached to the viruses that are trying to spread. It blocks their ability to get into cells, and it also triggers the phagocytes to gobble up those viruses and destroy them with digestive enzymes. Okay, so the two different pathways. And then a little bit about disorders. So the immune system being the complex thing, I hope you get a sense of how complex it is. It can either work not well enough or it can work too well. Okay, so we have two broad classes of immune system disorders, and that's autoimmune disease. Auto is self, so that's where the immune system is attacking the body's healthy tissues. And then we have immunodeficiency, where the immune system or some piece of it is not working well or is not working at all. All right, so here's an example of an autoimmune disease. Rheumatoid arthritis. You probably know people that have this. If you look at the elderly and you look at their hands, a lot of elderly people will have hands that have changed from young hands to old hands. But if you see hands that are deformed like that, that's rheumatoid arthritis. And what happens here is the immune systems of these patients, bless you, attack the joint tissues, particularly the small joints, so in the hands and in the feet. And as that joint tissue and capsule gets destroyed, the bones, basically, the joint stops working, and then the bones start to bend and change. Now, rheumatoid arthritis doesn't just affect the joints, it also affects many other things too. So it can affect the heart, it can affect the lungs, it can affect the liver. Rheumatism is an autoimmune disorder that can affect lots of different parts of the body. There are other versions of this. There's a juvenile version that afflicts children, and instead of hands, it's the big joints. It's the knees, the elbows, the hips, and they get basically arthritis at a very, very young age. So that's an autoimmune disorder. Technically, allergies are also an autoimmune disorder. Well, I guess they're not an autoimmune disorder, but they're an immune system hypersensitivity. Okay, so the immune system is over-functioning. It's attacking things that don't need to be attacked. And we already talked about allergies there. Transplant, organ transplant would not be possible without our understanding of the immune system that we have. Because people have been trying to do this for, more than 100 years. And it's only been since we could work with the immune system and know how it works that transplants have been effective. Because what happens if, let's just say you take a random kidney from one person and you hook it up in another. Well, what the recipient's immune system sees that non-self tissue as a giant pathogen, as a giant parasite. And the immune system attacks that organ because the body, the recipient's immune system is attacking it to destroy it because it's a pathogen. So that's rejection. You hear about organ rejection. Rejection happens when the recipient's immune system has labeled the transplant, we call it the graft, as a pathogen or as foreign material. So the only way that transplantation works is you have to pick the person you're going to take the kidney from to have them be a good match to the patient's own cells so that their immune system doesn't attack it and destroy it. That's rarely enough. You'd almost need an identical twin to have that be enough. Take a kidney out, put a kidney in, bye, see you back, next year. It's instead, people who've gotten a transplant have to take immune modulating drugs the rest of their lives. So it's a balancing act that the transplant folks walk, because you have to keep the recipient's immune system kind of slowed and a little dumber so that it doesn't figure out that kidney is not self-tissue. So they take immune-suppressing medications. Now, of course, that has effects, right? If you're taking immune-suppressing medications, it means you're going to get sick more often. And they do often get sick more often. And when they do get sick, they can get really, really sick because part of their immune system has kind of been turned down so that the kidney survives. We've gotten way, way better at this, though, as is evidenced by there are more and more transplanted different organs than ever before. It used to just be corneas and kidneys you could take out of one person and put them in another. Now they're doing hearts, they're doing lungs, they're doing pancreas, they're doing bowel transplants. They do bone transplants. They've even looked at doing muscle transplants and nerve transplants. So it's a really growing field. And pretty much the people that manage these patients with transplants are immune system doctors. So they're immunologists or they're rheumatologists. So that's a kidney ready for transplant, right? Is it a kidney or a heart? I think that's a kidney. Here's HIV. This is a super zoomed in picture. This is a T helper cell. The HIV virus, its preferred target is the helper T cells. So the way we determine how far advanced the patient with HIV is we count their CD4 cells, their helper T cells. And when their CD4 count is below a certain threshold, we say they have AIDS. So that's the deciding factor between if you have HIV or if you have acquired immune deficiency syndrome. And I know you've heard about AIDS many, many times, but it's a great example of an immunodeficiency. When your immune system doesn't work, you get sick. You get sicker than a normal person would have gotten sick from a virus. And AIDS is eventually fatal, at least it is in most people. And HIV is very, very difficult to treat because it mutates very rapidly. And it's just a bad actor because here's a virus that's attacking the immune system, the organ that's supposed to attack it, right? So it's no wonder why HIV is such a pain and is so difficult to cure or prevent It's because it's attacking the very system that evolved to attack things like it. So it goes in and destroys the very system that would have taken it out. All right. And then, I don't know what this one is down here. It doesn't say. It's probably under my thing. But we're out of time anyway. So we will stop there. Onward to the respiratory system. Remember, no class on Monday or Tuesday.